Hi, today I'm going to talk about Chapter 15, Therapeutic Procedures to Assist with Labor and Delivery, also Chapter 16, Complications Related to the Labor Process, and these are all found in your ATI book. So let's begin. So first we're going to start talking about the therapeutic procedures to assist with labor and delivery. So one of the things that could be performed is an external cephalic version. So this is the indications for this is for any fetus that may be in a breech or transverse position. So this is usually ultrasound is guided hands-on procedure to externally manipulate the fetus into cephalic line, done around 36 to 37 weeks. This procedure requires an informed consent form, and also need to explain the risk and benefits. They do an ultrasound screening prior to procedure to make sure to verify the position of the baby, where the placenta is located. They just want to verify to make sure the baby is well, is doing well. They'll do a non-stress test to assess for fetal well-being. This will require to have a ROGAM be given just because they're manipulating in terms of changing the position of the baby. And one of the risk factors that can happen is that it can, either the cord can go wrap around the child's neck. An accident, the placenta could be pulled, it could cause some bleeding. So there's a lot of risk when they do an eversion. So they need to be very careful. They will have administer tocolytic medication so that if in case that uterine contractions begin, it'll help minimize them or stop them at least. And you always want to have the OR ready because this is an invasive procedure, and if there's any complications with this procedure and that might require this baby to be delivered immediately, they have the OR ready. So the nursing care would be monitor vital signs and fetal heart rate, monitor for range of the rupture of membranes, because that can occur when they're manipulating to trying to turn the baby, assess for any uterine contractions, monitor for any bleeding, monitor the decreased fetal movement, monitor client for pain, and obtain the Klauer-Becky test, which to see if there's any maternal mix of the fetal blood and mother's blood. So let's talk about prolonged pregnancy. So this is lasts longer than 42 weeks. So one of the risk factors with pregnancy that goes beyond the due date is that our placenta has like an expiration date, so it won't work as efficiently to deliver oxygen and nutrients to the fetus. The fetus may lose weight as a result of this. Usually the skin may peel. They will continue to grow, but they're kind of running out of space at that point in there. They may expel meconium because they may go into fetal distress. There are low blood glucose levels in fetus. And again, the placenta ages because it only has a time frame of when it's fully functional. So any pregnancy that lasts longer than 40 weeks may require a non-stress test. As we know, that checks the fetal well-being. You need 2 accelerations within a 20-minute window. And the heart rate goes above the baseline for 15 seconds and lasts for, it goes 15 beats per minute for 15 seconds. They'll check the amniotic fluid index to make sure that it's adequate, especially because they can, especially they're looking for any oligohydramnios. They'll do biophysical profiles, and they also have the mom do fetal kick counts because again, we want to make sure the baby is moving. And usually they'll at this point start to schedule an induction if the baby hasn't spontaneously come on its own. All right, so we're leading into induction of labor. So induction is the deliberate initiation of to stimulate labor before spontaneous onset. So the provider is basically causing the woman to go in labor if she's not have gone already. So there's a series of things that they can use to induce the labor. But before we do that, I want to talk about augmentation. So the difference between augmentation and induction is the stimulation contractions after they have begun naturally. So essentially augmentation is we do interventions to kind of speed up the process or initiate the labor that's already started. So versus induction is that we actually start the labor that hasn't begun yet. So the methods of inductions are an administration of IV oxytocin, which the drug that we use is Pitocin, which is a synthetic drug that acts like oxytocin, which causes contractions. We also use cervical ripening drugs. These are some of these drugs also causes the cervix to ripen, to soften, so that it allows it to dilate and efface. Amniotomy is when they use the amniotic hook that I showed in class, which actually breaks the bag of waters so that it ruptures. They also do amniotic membrane stripping. Okay, so that allows for, again, for cervical dilation to take place. And sometimes they do nipple stimulation because, as we know, oxytocin aids in also, not only does it causes contractions, but it also causes the woman's letdown reflex in breastfeeding. So when you stimulate the breast, it releases oxytocin, which in turn causes contractions. One of the things that they do have to verify is the Bishop scoring, which this evaluates the cervical readiness to determine if the cervix is favorable for induction. So there's a series of scores, and if they score above a 6, it's predictable of successful labor induction because the cervix has ripened or softened in preparation for labor. So indications to induce a labor, it could be related to post-term pregnancy, dystocia, so some kind of difficult labor, prolonged rupture of membranes, infection within the uterus. If there's any maternal complications, gestational hypertension, diabetes, or pulmonary disease, or chorioamnitis, so there's some sort of infection, or fetal death. So again, the biggest thing with induction is that usually if they have to be 39 weeks or above to be able to have an induction. Now, there's certain medical conditions like gestational hypertension, placenta previa, placenta abruption, or any of those kind of things that if it's medically indicated that they need to have to be induced, then that's when they will do it less than 39 weeks. But they really have to meet the requirements, and there's usually a form that providers will have to fill out prior if they are planning to do this, so that we have a documentation. There's kind of sort of a hard stop that we're saying, okay, well, is this patient 39 weeks? If she's not, then we need to verify what are the medical indications. If they're appropriate, then you can proceed. If they're not appropriate and don't meet those criteria, then we need to follow up and determine what is the reason why they're doing that. If they don't meet the requirements, they will have to be required to have an amniocentesis to verify the lung maturity. Usually that will deter people from doing providers as well as patients if they decide to have an elective induction, because that amniocentesis is a very invasive procedure. But you just have to do that just in order to ensure the safety of the baby and the mother. So contraindications to labor induction will be the placenta previa. Obviously, most depending on if it's a partial or complete, which is verified prior to 37 weeks, they will determine whether or not these women may have to have a required C-section. Umbilical cord prolapse, abnormal fetal presentation, any high station of the fetus, active herpes infection in birth canal, abnormal size or structure of the mother's pelvis, or previous classical caesarean incision. Again, we need to check their medical history in order for us to determine if they are favorable for an induction of labor. So one of the types of induction of labors I talked about was oxytocin, which is an IV medication, which we call Pitocin, which is a synthetic form of the pituitary hormone that causes the uterine to contract. We need to explain the procedure to the woman because they are going to be admitted to labor, and they are going to be on this requires to be on an IV pump. and we initially titrate it as we go every 30 minutes. So we initially start off low with a low dosage, and then we keep increasing it and seeing how the woman and as well as the baby tolerates this, because now it's causing them to have contractions, which can be very it can be very painful, and it can and they usually come a lot stronger, these contractions, so we need to closely monitor. So we always want to get a baseline vital signs and fetal heart rate of the baby. Again, ensure the IV line is in place, is intact. Usually they'll remain in the bed for up to 2 hours or more. It could be long hours that they're in doing induction. Assess for signs of uterine tachysystole. So basically what uterine tachysystole is that because we're causing this woman to contract, we don't want her to contract too much where it can be excessive. So uterine tachysystole means that there's more than 5 contractions in a 10-minute window. So if she's having more than 5, then we need to assess the baby and mother, and sometimes we just have to titrate down because now we're giving too much medication. We don't want to hyperstimulate the uterus, because then that can affect the baby in terms of the baby not being able to get enough oxygen and nutrients to the baby, especially during the contractions, because it's causing that head compression. So now it's stimulating it too much, and that can decrease the fetal heart rate. So again, we need to be careful we need to be monitoring very closely how we're titrating this medication. Again, there's complication with oxytocin induction. It could be a potential risk for a C-section, because again, we're hyperstimulating this uterus. And when we hyperstimulate this uterus, it can cause water retention. So women can this can be a problem if they have this water retention. They can have hyponatremia. This can lead to confusion, convulsions, and coma. So we need to be very careful when we use this drug, because this can be potentially harmful. And it can, because this can cause water intoxication and hypertension as well. We just need to make sure that we monitor vital signs frequently, assess for signs of water intoxication. So the patient may become drowsy, they may have headaches, or they may be anorexia. So again, we need to be teaching the patient about the medication as well as the uterine cramping, and just to let us know if it's really severe. We'll also notice a non-reassuring fetal heart rate. Because it can cause water retention, it can even increase the risk for the woman to have congestive heart failure and can lead to death. So again, if you notice some foamy sputum coming out of the patient's mouth, then that can mean really serious. So we need to be very careful with this medication. Nursing interventions, again, position the patient on the left side. Again, more tissue perfusion to the baby. Maintain IV open and infuse IV fluids. Administer 8 to 10 liters of O2 via face mask, and administer tocolytic medication and assess fetal heart rate. Okay, let's talk about cervical ripening. So this is various methods increases cervical readiness for labor through promotion of cervical softening, dilation, and effacement. So the indications for this will be augmentation of induction of labor, failure of the cervix to dilate and efface, and failure for labor to progress. So types of prostaglandins are cytotec, misoprostol. We have prostaglandin E2, which is Prepidil or Cervidil. We also have a balloon catheter that actually opens and causes the cervix to efface and dilate. We do membrane stripping, and then there's a hygroscopic dilator. So these are just different types of ways that they can that have the cervix dilate and efface. Even sometimes before we even do all this, sometimes we even recommend that the woman have sex. The semen of the man can also be utilized as a form of prostaglandin, and it actually helps ripen and helps the woman dilate. So sometimes we have them before we get to that point for induction. We will encourage them to have sex as long as they feel comfortable, as long as there's no contraindications to having sex. Sometimes that can help as well. So nursing actions: assess for urinary retention, rupture of membranes, uterine tenderness or pain, contractions, bleeding or fetal distress, or any hyperstimulation when you give this medication. So let's talk about amnio infusion. Amnio infusion is, I showed you in class, when a woman has to have internal uh, fetal monitoring. It allows, not always, but it does have the capability of providing an amnio infusion because it can connect to the IV line. So if the woman hasn't received an internal fetal monitoring, then they would have to get the internal fetal monitoring to have an amnio infusion. So basically what this does is that it connects to IV, the internal fetal monitoring connects to the IV, and they're allowed to administer normal saline into the abdominal cavity through the transcervical catheter to supplement the amount of amniotic fluid. So if this person is experiencing oligohydramnios, where they don't have enough amniotic fluid, then they can infuse this in the abdominal cavity, especially like if you're having like a prolapse cord. This is where it can be useful if we have a stable heart rate. So again, indications are oligohydramnios or fetal cord compression. So again, we need to warm the fluids prior to infusion so that they're warm, because you don't want to cause it to be too cold. Maintain comfort and dryness. So you want to be placing chucks underneath her buttocks and making sure that you're changing them frequently, because she's going to be leaking. The last thing you do is you want is your patient to be uncomfortable and wet, and increases the risk for skin breakdown. You want to monitor for uterine overdistension and urine output. So you don't want that to get her uterus to expand too much, because then that can also put her at risk for postpartum hemorrhage afterwards. And then you want to monitor the fetal heart rate and contractions as well, and see how baby is doing. So amniotomy is the artificial rupture of membranes by the provider using an amnio hook. This is usually indicated for labor progression when labor is too slow. It can be used for augmentation or induction is indicated. It usually, once they break the bag of water, it commits the woman to delivery. So you need to be making sure that when they actually break the bag of waters, that the provider will indicate whether this is clear. Remember the code acronym, the color, you're looking at the odor, the amount, and the time it was done, and making sure that it's not meconium stained, because if it's meconium stained, then we need to initiate the team, which is your neonatal team, and your nursing nurses need to be there when the baby delivers. We also need to make sure that we're monitoring the temperature to make sure there's no risk for infections, especially if it's past 24 hours. Increases the risk. If she does start having an elevated temperature, then we need to administer antibiotics. This stimulates prostaglandin secretion. So the complications with doing rupturing the membranes, it can prolapse the umbilical cord, because sometimes when you break it, it may cause a gush of water. So a gush of that fluid may come down, and sometimes the umbilical cord can pass through depending on where the head is at. Especially if the baby's not fully engaged in the pelvic. It can cause infection, and then it can potentially cause a placenta abruption. So we want to be monitoring the fetal heart rate and making sure that it's within its normal range, 110 to 160, because if it's lowers or if there's some deceleration, especially variable decelerations, then we're going to suspect that it's umbilical cord prolapse. Again, looking at the color, the odor, the amount, and the character of the amniotic fluid, checking your temperature, and then of course looking at for if they're MEC stained at all. All right, so let's move on to complications related to the labor process. And this is your chapter 16 in the ATI book. So prolapsed umbilical cord, and you'll hear it say umbilical cord prolapse. They kind of use it interchangeably. So this is when the cord slips down in front of the presenting part, causing compression of the cord and compromising fetal circulation. So again, when with this is very serious. We gotta intervene quickly, because this can potentially be harmful for the baby, especially if they're having variable decelerations. So the risk factors is that the membrane ruptures with fetus at the high station. Fetal is premature and small, so it kind of slips through. There's abnormal presentation, small for gestational age, or they have a long umbilical cord. multifetal pregnancy or unengaged presenting parts, or polyhydramnios or oligohydramnios can increase the risk. So expected findings: the client's feeling that something is coming through the vagina so they can actually feel it. The umbilical cord is visible and palpable, and of course you're going to notice on the monitor that there's these fetal heart rate is variable deceleration, so they're like these really abrupt V's that you see, because just imagine it's almost like someone's just grabbing that cord and compressing it, so it's altering that circulation immediately to that baby. So again, this will sometimes require prepare for immediate birth or a C-section, depending on how how's the baby's fetal heart rate. So again, you want to, when this occurs, you want to call for assistance immediately. You never want to leave the patient alone, so call for assistance. Turn on the nursing call light to call for help. We want to notify the provider as well. If it's causing those really bad variable decelerations, you will need to don on a sterile glove. You have to don on a sterile glove and insert 2 fingers into vagina to help elevate the cord, because then you want to see on the monitor, has this helped to decrease, help avoid having those variable decels. But usually once you place your fingers, you kind of commit to being there until the baby's delivered, or whether they transfer the baby to the OR. We also want to place the woman in knee to chest position. Either it can be knee to chest, Trellenberg position, or sideline with a roll towel under the right or left hip to relieve pressure. You want to apply warm, sterile saline soaked towels to the cord to maintain it hydrated and prevent it from drying or sticking. Administer oxygen, 8 to 10 liters, because again the cord is compromised, so we need some more oxygen getting to the baby as well as mother. Again, we're monitoring the fetal heart rate and assessing for fetal hypoxia. At this point, we're preparing for immediate birth, whether it's a vaginal or C-section. Most of the time it leads to C-section, but it just really is dependent on how the baby heart rate. That's really what we're looking at to see how the baby is doing. Again, you want to document the event, action taken, and the client's response. So, and sometimes women will have a dysfunctional labor, which we call dystocia, where the woman does not progress, or she just has a difficult labor. Some of the risk factors for dysfunctional labor could be advanced maternal age, obesity, overdistension of the uterus. They can have hydramnios or multifetal pregnancy, abnormal presentation. They may have cephalic pelvic disproportion, or overstimulation of the uterus, maternal fatigue, dehydration or fear, which causes her pain to increase and just causing her not to be able to progress, or there's the lack of analgesic assistance. So a lot of times they have meconium passage in the amniotic fluid during antepartum period prior to the start of labor. They may have risk factors. Are 38 weeks maturity or normal physiological functions. They may have umbilical cord compression, hypoxia, which can stimulate the vagal nerve. Or there can be something related to respiratory distress in the baby. I'm sorry, not respiratory, but just stress in the baby that causes this baby to pass meconium in the amniotic fluid. So usually when they yes, again, we tell them to know the code acronym. The mother would identify that the amniotic fluid is black or greenish tinge, or yellow or brown, or we will verify that when she comes in and when we assess the amniotic fluids. Often presents in breech presentation sometimes, but there's sometimes the fetus will not present with any change in the fetal heart rate. They may have stained fluid accompanied by variable or late decelerations. So again, the diagnostic procedure is to put them on the electrofetal monitoring to assess how the baby's heart rate is doing, because that will really tell us if this baby is any type of distress. And we'll notice some decelerations. Document the color and consistency of the stained amniotic fluid and making sure you know the time, because now this increases the risk for infection, especially if it's past 24 hours. Again, we notify the neonatal resuscitator team so that they can be there at the delivery. We also gather equipment for neonatal resuscitation, so your suctioning kit and everything, to make sure that we suction that baby immediately after birth, and have especially because we don't want that baby to ingest any of that fluids or go to the lung, because then it increases the risk for infection. Okay, my computer got a little stuck, so let me just adjust it. Continue. Sorry, I had a little technical difficulties. So let's continue with dysfunctional labor, which is called dystocia. So this occurs because of a malfunction in one or more of the 4 P's of labor. So you can either, it can be the passageway where the pelvis may be small or contracted due to disease or injury. It could be the passenger, which is fetus may be malpositioned or excessively too large, which we call macrosomic. Or there could be multifetal or birth defects that can cause a dystocia. Then we have powers, which it can be insufficient uterine contractions. They're the quality or the quantity. So this may require that for an intervention where they may need to introduce Pitocin so that it can help increase those contractions so that it can cause the woman to progress. It could be the psyche. Women may fight contractions due to the tension because of fear or intense pain. So there's a frequent combination of factors that results in the dysfunctional labor. So you can have abnormal fetal presentation or position. So the abnormal fetal presentation or position is that prevents the smallest diameter of the fetal head to pass through the pelvis diameter of the pelvis. So again, sometimes people that are at risk for this is young girls who have cephalic pelvic disproportion, because sometimes their hips may be they're not matured yet, and so they may have small hips where it can sometimes cause some complications during delivery. So it does not pass easily or interferes with the most efficient mechanism of labor. So sometimes even when the cardinal movements as they're moving, they can sometimes get stuck. This may cause cord compression, may require external version. Abnormal position, common cause is a fetus that remains in a persistent occipital posterior position. So that's when the baby's spine is aligned with the mother's spine, and so this is where it can be very, very difficult, painful labor for the woman, because they're just bone and bone is grinding. So that's why we try to put the woman in hands and knee position, so that it helps alleviate some of that pain, because it drops the baby down a little bit. It also allows room for the baby to kind of actually move to the correct position. That's where we're doing counter pressure on the mother to also help with the pain, to help alleviate that. Labor may last longer because of the way this baby is in this position. And again, they experience intense and poorly relieved back and leg pain. Sometimes these babies may require a forceps assisted delivery. So nursing care for abnormal fetal presentation or position is encourage women to assume positions that favor fetal rotation and descent to reduce back pain. Again, I kind of explained this: the sitting, kneeling, or standing with leaning forward. Rock the pelvis back and forth while hands and knees to encourage rotation. Sideline. They can do squatting in the second stage of labor, or lunging by place one foot in the chair with the foot and knee pointed to that, because again, it opens up, so it allows the rotation of the baby as well. Now we're going to talk about shoulder dystocia, which is a big complication in labor. Basically, the fetal head delivers, shoulders get stuck in the pelvis, preventing delivery. This is an emergency. It's pretty scary when this does happen. Baby must be out within 5 minutes. So when this is occurring, it's almost like they call a timeout. So they have to get everybody in place, and someone has to be documenting when the time was called for shoulder dystocia, because they literally have 5 minutes to get this baby out. Otherwise, they got to proceed to having this baby delivered as a C-section. So again, there's maternal and fetal risks, there's injuries and it could potentially cause fetal death, especially because time is the essence and this baby is being stuck right at the vagina because the head is delivered and it's almost like the vagina is basically choking the baby. So they're not getting enough oxygen. Fetal chest cannot expand and the fetal needs to be able to breathe. So a lot of these risk factors are macrosomic babies. They do ultrasounds, but not necessarily do the ultrasound are always accurate. Sometimes it could be 10% off of the weight. Maternal diabetes are increased risk factor because as we know, these babies can grow really large. And so that's why we have to have her control her blood glucose sugars, because the baby's glucose has no problem with like a mother with diabetic. Their pancreas is fine. So again, the clinical manifestations is that they have this turtle sign, which as you see in the top picture, the baby's head is stuck right there. Treatments is a McRobert maneuver. This is where they put, if you look at the diagram, they put pressure. So they put the leg up and they put suprapubic pressure to allow that shoulder to come out. And if you watched the video, we kind of watched it and you also saw the maneuver and how it's done. There are other maneuvers, but McRobert maneuver is kind of the first maneuver that they do, and then they have other ones. But again, you don't have that much time, so you have to act fast. After delivery, mother and infant need to be assessed for injuries. Mother may have torn perineal tissue. More at risk for uterine atony and postpartum hemorrhage. Uterus does not contract well after birth, so this put the woman again at risk for postpartum hemorrhage. Uterine atony means basically the uterus can't contract because it's overstretched. Infant may have fractured clavicle, so we need to assess the baby as well. Precipitous delivery is the labor that lasts 3 hours or less from the onset of contraction to the time of delivery. So there's risk factors can include hypertonic uterine dysfunction, oxytocin stimulation, it's too much, or they have a multi-parous client. So usually these women will have low backache, abdominal pressure and cramping. They have increased bloody vaginal discharge. They have palpable uterine contractions. They progress of cervical dilation and effacement. So these women progress really fast. They may have diarrhea, fetal presentation, station, and position. So this baby's like ready to go. Come on out. Possible maternal perineal area laceration or trauma. Because it's so fast, it doesn't allow the woman her body to prepare for labor, so it can, she can have some lacerations as a result of this. So again, we want to assess for trauma to the neonate as well as the mother after delivery. So if this is happening, do not leave the patient alone. Call for help, press the call light, stay with the patient, try to maintain the patient calm. You can place the patient in a sideline position, again, to promote oxygenation. Encourage it to breathe, a nice deep cleansing breath through contractions. You're not attempting to stop delivery. What we want to do is you have to immediately get on some gloves, put on a gown, because you probably more likely will going to be delivering the baby if we don't get that help right away. So your job is to try to be there at delivery, and if the head comes out, you have to hold the baby's head and guide the baby out, suction for the fetus, mouth, and nose, and hopefully by then you'd have help to assist you in terms of making sure that the baby and mother are safe after delivery. Uterine rupture, this is where the uterus will rupture. It tears open, exposing fetus and uterine content to the peritoneum. A lot of risk factors, it can be congenital uterine abnormality, uterine trauma, overdistension of the uterus. There can be hyperstimulation of the uterus, so that could be if they're having this oxytocin being given, the pitocin, and that can hyperstimulate, so that's why we're watching out for that uterine tachysystole. External or uterine fetal fusion. because again, we're manipulating the baby to move in a position, so you can potentially affect the uterus by doing that. Forceps delivery and people with multigravida can also be at risk because your body is just constantly having children and expanding your uterus, so it just kind of puts it at risk. Just think of that rubber band where we're constantly stretching it and stretching it and stretching it, so sometimes that muscle can't go back to normal, and sometimes it can just break. So that's kind of what happens with uterine rupture. So clients will report sensation of ripping or tearing or a sharp pain. Also abdominal pain and uterine tenderness. Sometimes you may not get a non-reassuring fetal heart tracing because the uterine has ruptured. Sometimes the uterine shape and palpable parts of the fetus. Sensation of contractions and loss of fetal station, and there's going to be potentially manifestations of hypovolemic shock. So again, the preparation for cesarean section will, so this got to immediately go for a C-section. We got to make sure to deliver this baby safe. Usually this may require for the woman to have a hysterectomy depending on how severe the rupture, how ruptured her uterus is. We need to administer IV fluids, administer oxygen to the baby so that we can get more oxygen to the baby until we get this baby out. You may need to administer blood products because of depending on how much loss you might have had. And we need to monitor for signs of shock and treatment. So we're going to be giving her oxygen, IV fluids, and blood transfusion. Again, prepare for C-section and provide emotional support because this woman's going to be scared to see this happen, especially when she sees her uterus rupture and potentially see her baby coming outside her peritoneum. Anaphylactoid syndrome of pregnancies is amniotic fluid embolism. This occurs when there is a rupture in the amniotic sac or maternal uterine veins accompanied by high uterine pressure that causes infiltration of the amniotic fluid into the maternal circulation. Meconium-stained amniotic fluid can cause devastating maternal damage. So the risk factors for this is multiparity and advanced maternal age, placenta previa and abruption, preeclampsia, eclampsia, Oxytocin administration, diabetes, C-section, forceps-assisted delivery, uterine rupture, cervical laceration, meconium-stained amniotic fluid. Patients will report sudden chest pain or sudden shortness of breath, respiratory distress, indications of coagulation failure, so they're just bleeding out, indication of circulatory collapse. So again, we want to administer 8 to 10 liters of O2, assist with intubation and mechanical ventilation, perform CPR, administer IV fluids, position the client on her side with her pelvis tilted at 30 degrees to displace the uterus. We need to be administering blood products, insert a Foley catheter to measure output, monitor maternal fetal status, and prepare for emergency C-section. All right, this concludes the lecture.